Hello, everyone. My name is Amin Jaromi. I'm one of the radiology and nuclear medicine residents at University of California in San Diego, and it is an honor and pleasure for me to be talking to you guys today um, about identifying unknown whole body nuclear medicine images. My email is here. If you have any question or comments or feedbacks, feel free to reach out. Also, if I can help you in any other way, please don't hesitate to contact me. Okay, so let's start here with the first slide. So tips for identifying whole body images can be divided in two categories, either level of the counts or biodistribution of radiopharmaceutical. Level of the counts can be divided in three groups: high counts, medium or low counts. High counts constitutes of PET radio tracers and such as FDG, sodium fluoride, bone scan, oxyumin, and gallium dotatate, as well as technetium 99M, which is the workhorse of nuclear medicine. Medium counts are radioisotopes that have a higher half-life, so the dose is less, and that causes less amount of counts and higher noise, so it falls on the medium count category, including gallium, thallium, and indium, all with almost 3-day half-life. Low counts have the longest half-life and the longest duration after the injection of radio tracer, so the noise is the highest, the count is the lowest, including indium white BC scan, iodine, either for MIBG scan or sodium iodide, as well as Y90. So this finding the level of the counts is kind of subjective and it needs some experience. Also, it cannot pinpoint exactly what is the radiopharmaceutical. For example, these are three images of high, medium, and low counts. Technetium MIB, thallium, and iodine 131. So the best way to find out what radiopharmaceutical is used and what is being imaged is using this chart that I'm going to share with you. So by looking at three organs, including bone, liver, and spleen, you'll be able to figure out what whole body imaging you're looking at. So first thing to look for is bone uptake. So if bone uptake is present, you go to the upper half of the chart. If it's absent, you go to the lower half. And if it's present, then you look at liver and spleen. If there's no liver and spleen, then you're dealing with technetium bone scan. If liver is higher uptake than spleen, then you're dealing with gallium. If liver and spleen are almost equal, then you're looking at technetium sulfur colloid. And if liver has less uptake than spleen, then you're looking at indium white BC scan. So no liver spleen, it's technetium MDP bone scan. So it is easy to remember because it's a bone scan, so it only shows you bone uptake. And then for the other three, think about this mnemonic GSW or gunshot wound. So G is if the liver is hot, S if are equal, and then W if the spleen is hotter. So gunshot wound from right to left, stands for gallium, supercolloid, and indium white VC scan. Then in the lower half of the chart, if there's no bone uptake, but you see liver and spleen, then you have technetium system because it gets cleared by hepatobiliary system. And then if there is only liver uptake, then you're looking at MIBG scan, either I-131 or I-123. And if you have no liver or spleen and no bone, so basically no uptake in any of these three organs, then you're looking at sodium iodide, I-123 or I-131. So if you have this chart in your mind, then you can pretty much differentiate every whole body nuclear medicine image that you can think of. So now let's go through some images to practice this chart and consolidate it in our minds. So the first one, so you see bone, yes. So you move to the upper half of the chart, no liver or spleen, it's MDP bone scan. And then you see uptake in the sternum and in the left clavicle. So it can be metastatic bone disease in this patient with history of breast cancer. And this is the CT correlate showing sclerotic expansile bone lesions in the sternum and left clavicle. Next one. So bone, yes, present, liver and spleen. Spleen is hotter than the liver. So now remember the mnemonic GSW. So this is W, stands for WBC scan. And what is this uptake? It correlates over the abdominal aorta. So it is aortic graft infection. Then next slide is you see bone uptake, and then the liver and spleen are equal. And so and then the way to know that there is a splenic uptake is that, so obviously liver you can see, but for the spleen you see scattered signal in the area of the spleen, so not necessarily focal as you might expect. So this is consistent with sulfocolloid in a patient with splenosis, a finding not uncommon in San Diego. So it's a patient starts post-splenectomy after being kicked by a horse, and these enhancing nodules scattered in the peritoneum correspond to a splenosis. Okay, so next slide, again, bone is present and spleen is hotter than liver, so it's a indium white VC scan. The pathology is on the right lower lumbar spine area, corresponds to a left lower lumbar paraspinal abscess. And this is MRI confirming a ring enhancing fluid collection in the left lower lumbar paraspinal area consistent with abscess. Okay, next one. So you see bone, yeah, kind of. You see some uptake in the area of vertebral column. You don't necessarily see splenic or liver uptake. So you're thinking about bone scan. So the question that I have for you guys is, what medication is this patient on? So the answer is bisphosphonates. So patients on bisphosphonates, because of the inhibition of uptake of MDP by the bones, you see increased residual uptake in the soft tissue. So remember that if the bone scan looks a little hazy with soft tissue uptake, you're dealing with a patient on bisphosphonate treatments. Next one, another bone scan with present bone and absent liver and spleen. So if you pay attention to the lower extremities bilaterally, you see linear uptake in the femurs and tibias. So this is consistent with hypertrophic osteoarthropathy in this patient with lung cancer. This can have a laundry list of differential diagnosis. Just to remember, things that cause low O2 sat can cause it, as well as lung cancer, Hodgkin lymphoma, thyroid, or thymus tumor. And then next one, you see uptake in the bone and higher uptake in spleen than liver. So this is another indium 111 white BC scan. So here in the posterior images, you see a pattern that kind of looks like star. It's called septal penetration, and it happens when the collimator that is being used is for a lower energy. So the high energy of indium 111, which is at 187 and 240s keVs, penetrates through the collimator septa. So it gives you this pattern. So in the anterior images, the collimator was changed and you don't see that septal penetration and star artifact. Okay, so next one, what is this study? So you see bone uptake? Yes, you do. Do you see liver or spleen? You see liver more than spleen, so this is gallium. And which uptake is abnormal? So for gallium, uptake in the lungs are abnormal. So if there is pulmonary uptake, then you think about fibrosis, infection, or tumor. Next one is another bone scan. What is the diagnosis? So you see continuous uptake throughout the whole left tibia and in the right sphenoid bone and multiple bilateral ribs. So this is Antmini presentation of fibrous dysplasia. So this is a polyostotic fibrous dysplasia. Next one, you see bone uptake with liver higher than spleen. So remember GSW mnemonic. So this is gallium again, 96 hours. So this is a patient that was concerned to have myocarditis. So you don't see any uptake in the myocardium. However, you see uptake in the right greater than left kidney. So this it represents interstitial nephritis bilaterally in right greater than left side. How about this one? Is another gallium study. However, the image is hazy. And then when you move to the right energy window, which is to the easiest way to remember is 90, so 90, 190, 290, and 390. Then the image becomes sharper with higher resolution. So this is a gallium scan. If you see this haziness, it corresponds to wrong energy window. So what organs function should be monitored in this patient? So this is a first step is to find what is this scan. This is NDP technetium 99M bone scan because you see bone uptake but no liver or spleen. So the abnormal pathologic uptake is in bilateral psoas muscles. So it corresponds to rhabdomyolysis. So this patient should be watched for renal function to prevent renal failure. Okay, so now let's move to the lower half of the chart when there is no bone uptake. So when there's no bone uptake in this patient, you only see liver, so it is consistent with MIBG. And then next one is another MIBG, only liver, no spleen, and no bone. And then this uptake in the right adrenal gland corresponds to right adrenal pheochromocytoma. Next one, you don't see any bone uptake and no spleen and no liver uptake. So this is consistent with iodine 131 or 123. It's you don't really have the ability to differentiate between these two accurately, but this one is a post-therapy patient, and so this you see the septal artifact, septal penetration artifact, star artifact again, because of the high energy of iodine 131, which is 365 electron volt, kilo electron volt, and then this is consistent with residual metastatic thyroid cancer in this post-treatment patient. Okay, so what is the diagnosis in this patient? So this is actually not a MIBG scan, although you see liver uptake. So this is a pathologic iodine 131 scan. So you see uptake in the thyroid bed as well as diffuse uptake in the liver. So this is a case of residual metastasis. So this residual thyroid cancer incorporates radioactive I-131, and it gets catabolized in the liver, gives you this diffuse liver uptake. Next one is a study with low count and no bone uptake and only uptake in the liver. This uptake in the area of right adrenal gland corresponds to right adrenal pheochromocytoma. This is a CT correlate. You see hyperenhancement in the arterial phase that does not wash out, so it excludes adenoma. And then always remember that if the arterial phase enhancement goes above 110 Hounsfield units, there's a high chance that you are dealing with pheochromocytoma. So now let's look at some PET radio tracers. So this is normal gallium dotatate biodistribution. So the normal uptake of gallium dotatate that you have to know is pituitary gland, in salivary glands, thyroid, spleen, liver, adrenal, kidneys, and bowel, as well as urinary bladder. So in this patient, it resembles that a normal gallium dotatate scan. You see no brain uptake, so it's not FDG. So the abnormal finding in this patient is in the lymph node, in the abdomen, and in foci of uptake in the liver. So it's consistent with metastatic neuroendocrine tumor. So this one is normal by distribution of oxyumin. Intense uptake in this liver and in the pancreas, and this patient has a focal uptake in the right supraclavicular lymph node, which is consistent with metastatic prostate cancer. So what is this radio tracer? So you see some uptake in the brain, but intense uptake in the bones and in the spleen. So it's not normal, it's a pathologic, but it is F18 FDG and differential is granulocyte colony stimulating factor therapy or lymphoma treatment or lymphoma. So these two can give you this pattern of uptake diffuse in the bone and in the spleen. So always remember to correlate with prior studies and history of GCSF treatment. So this one is another FDG scan. You see some uptake in the brain and the liver, in the myocardium, and then this abnormal increased uptake in the soft tissue and in the muscle can be seen when the blood glucose level is elevated. So in this case, basically you see this abnormal uptake in these muscles, and this can obscure malignancies. So we did a study to compare glucose correlated SUV max with normal non-glucose corrected one, and we found that SUV that is corrected by glucose level has a higher area under the curve in the ROC curve, and it differentiates benign versus malignant pulmonary nodules more accurately than the other traditional SUVs, such as SUV Max, SUV corrected based on BMI, based on body surface area or cerebellum. And this is the area under the curve. So the solid dark line corresponds to glucose corrected SUV. And then so it is has the highest area under the curve, so highest accuracy. And then remember that FDG tracer has a 3-compartment model of kinetics, and the net uptake rate is K1 times K3 divided by K2 plus K3. So if you K or net uptake rate is an indicator of SUV max, but if you multiply it by blood glucose level, it becomes an indicator of glucose metabolism rate, and that's why the correction helps with the accuracy in differentiating benign versus malignant lesions. So it is recommended that for patients with high glucose level to correct it based on glucose. So with that, my half an hour time is up. I thank you all for listening, and feel free to reach out to me if you have any question or any comment or any feedback. And my email is in the first slide.